Welcome again, and I would like to introduce Corey Feist, who's CEO of a very major foundation, not very old, but very major foundation. This is Dr. Lorna Breen Heroes Foundation, and we are very lucky that we have Corey joining us. He very much wanted to be in Boston in person, but somehow that has not been possible. But Corey, thanks for finding the time and joining us even remotely. We are all waiting to hear from you. And as we explained earlier, it's about 30 minutes for your presentation, and then we will open it up for discussions, questions, and so on. And the topic that you're covering is so very important for the agenda of the department and indeed of the school. It should be an important agenda for all of us, wherever we are. So with that, I would like to hand it over to Corey. But before that, I have a disclaimer which our lawyers want me to say aloud that the opinions of the speaker are their own and do not represent the views or opinions of Harvard University. Bear with me, I have to say that and you have to listen to it. But with that, hand it over to Corey. You.
Thank you, Shikar. It is an honor to be with you all today. And I would just say, to the extent that any of you are comfortable, this is an intimate group. Please feel free to take yourself off of video mute, and we can engage in a conversation here. Working with Shikar now for the last few years on this effort has been one of my greatest professional achievements. And even though it was grounded in family tragedy for us. So when Shikar reached out and asked if I could make the trip, I was trying so desperately to fit it into my travel schedule, especially since he was in the United States, a rare thing, at least in my experience with Shikar. So we'll be there next time, I promise. I'm going to go through a few slides to orient you to our work, and then would love to have a conversation with you. And when I say our work, one of the things that I want to make sure you recognize as we begin the conversation is that Harvard T.H. Chan School of Public Health played and continues to play an important role in the work of our foundation. And I give 100% credit on that to Michelle Williams, whose leadership, her vision at the beginning of this pandemic around who's going to care for the caregivers really helped to create this partnership. When I go across the country now and I speak about the workforce, one of the first things that I do is I ask healthcare leaders a series of questions when I'm in the room. I ask them, what type of well-being services do you offer as an organization? I ask them, what is your current utilization of those services? And I always ask them, are they meeting your goals? And what I often get is a look back at me saying, well, sure. I mean, we have employee assistance programs, we have counseling, we got this great meditation app. Also, we got yoga now. It's amazing. And people sort of use it. It's mixed. I don't really understand, they will often say, why physicians and nurses won't use formal counseling services. I've got a whole building of counselors, but they won't go get formal therapy. And our EAP program in our hospital system, it's underutilized. So, they say, Feist, I have no idea what our current well-being goals are. Like we don't have them. We've never had them. We haven't had to think about this kind of a thing. We just thought EAP and HR, they would handle all these things. So then I get them thinking, and I go on and I say, okay, let's pivot a little bit, and because it's in business, you got to use business language like pivot a lot. So I say, hold on a minute, let's talk about turnover. And by the way, has that changed in recent years? Then I say, you have an entire quality improvement infrastructure, I'm guessing, educated guess. Tell me about the costs associated with how much you're investing every year in that. And I bet you have revenue at risk associated with whether you meet these quality metrics or not. And then I say, okay, now let's talk also about this massive investment you've made in the last 15 years in information technology. You've put in electronic medical records. You were incented to do that. You've spent hundreds of millions of dollars doing that. You continue to update these services. How much are you spending on that effort? How much are you spending on optimizing that effort? And then when I talk, the answers that I receive to those questions are usually like, well, a lot of dollars, a lot more dollars, and yeah, we keep throwing tons of money at this IT issue that we have. So I say that to them to get them thinking about the way that we as a foundation really think about this conversation around well-being, and that is that we need to think about more holistically this concept of what we talk about when we talk about well-being. So I know I'm in an academic institution. Every academic institution needs a Venn diagram. I think it's part of the contract that Shakar made me sign to come here today. But this is one that we have created at our foundation as a way to speak about the issues of well-being, and we put them in the domains of burnout and then depression, anxiety, and substance use because those are different things and the root causes of those are different. The issues and challenges are different enough that it's important for us as we think about an approach to address these issues that we know what causes them. And so from a burnout perspective, we always talk about the fact that burnout is not a mental health condition. It is an occupational syndrome. It is driven by the workplace. When burnout increase, or when the stress and the working conditions get worse in an organization, burnout increases. When the stress is mitigated, burnout decreases. And yet, the vast majority of the response by employers to the workforce, particularly during the last few years, to this increase in the burnout conversation has been in this second bullet, individual support. When you talk to those health leaders, they go, well, we have a meditation app, we have yoga, we have EAP. What we've done is we've shifted this burden, we've kept this burden on getting out of burnout on the workforce. Yet burnout is caused by the workplace. So we have a mismatch. So what we need to really focus on, which is why we list it first, is the underlying systems that drive burnout in the first place. Then on the right side of this, we talk about depression, anxiety, and substance use disorders because those are formal mental health conditions. And what we need to understand about those is for licensed health workers in the United States of America, they have penalties and barriers for obtaining mental health services that are distinct from those that I have as an attorney. Let me pause and rewind because this may need a new concept even to you in the school. That in most states and in almost every hospital system in the United States of America, health workers are being asked questions about their prior mental health, which violate the Americans with Disabilities Act. And they serve as a barrier and inform and as well a penalty for health workers of getting mental health care. So we need to knock those out. That's part of our attack plan. We also know that there are very good systems that have been developed to screen for suicidality. When someone gets to a point where their mental health condition is tipping them into having suicidal ideation, we know that we want to screen. And one of the reasons for that is because the rate of suicide among the healthcare workforce is among the highest of any type of worker. Now, we all know in the United States in particular, first responders, the military in particular, we're conditioned to know that their suicide rates must be high because we talk about it all the time. But did you know that the suicide rates of doctors and nurses is actually higher than that of the military? Well, they are. They're twice that of the general population. So we know that this continues to be an issue. And then finally, because of the stigma associated with mental health care, we need to make sure that the workforce has confidential access to care. And then, as you all know, in any change initiative, leadership and culture with a little leadership and a lot of culture, right? Actually, it's a lot of both. Those are the ultimate accelerators of the change or potentially inhibitors. So that's where we really are focusing as a foundation to make sure that they understand these issues. So why do we do this? We do this because my sister-in-law died by suicide. She's 49 years old. She's an emergency medicine physician. April 26th, we are almost there. April 26, 2020, Lorna took her own life because she was burdened by a lot of the things that we talked about. After a singular mental health episode in her career, she was getting her MBA at Cornell. She was a healthcare leader in New York City, running one of the busiest emergency rooms. She was a clinician herself, and she is no longer here because of the culture, because of the workplace, because of the penalties for getting mental health care. And so we began this journey, kind of a journey of the response by the workforce to the national publicity following her death, which many of you may now remember when from the early days of the pandemic. So our focus as a foundation is to reduce the burnout of healthcare professionals and safeguard their well-being and job satisfaction. We envision a day when seeking and obtaining mental health services for the healthcare workforce is a sign of strength. But we don't just do this for Lorna, because Lorna's not here anymore. We do this for all health workers. And we don't just do it in honor of Lorna, even though her name is on our foundation. We do it for Matt Gall, who was a doctor who moved from Minnesota to North Carolina. And he was under the assumption that he was going to be penalized in his license in North Carolina for getting mental health treatment. He died on Thanksgiving Eve, 2019. We do this for Scott Jolly, who was an ER doctor in Utah, who was only allowed to use the mental health services of his hospital system because that's all his insurance would cover. He was so burdened by seeing his colleagues as he was being wheeled out of the inpatient psych unit that he died by suicide days later. We do this for someone who was in the Mass General system. Lisa Lerner was a dermatologist in the Boston area whose adolescent son died due to a medical error. And as a mom, she was so grieving that loss that she would drive counties away from her home, use a pseudonym and pay in cash to simply get mental health treatment. But Lisa and her family just could not take that burden anymore. She died by suicide. Dr. Mo Brown, an orthopedic surgeon in Idaho, similarly burdened by the stigma of mental health care, died after he struggled during the pandemic. And then recently, Tristan Smith, a nurse from Ohio, who left a message on her laptop that her father read to me, which is a letter to my abuser, is what it's called. And I'll read from that in a minute. But then most recently, a resident at GW, just a little south of you all, Will West. I talked to his dad yesterday. Will died by suicide because of the working conditions and his fear for getting mental health treatment. I want to read just very briefly from Tristan's letter. I read this to the United States Congress on February 14th when I testified before the House Energy and Commerce Committee. She says, ever since I was young, I expressed interest in healthcare and becoming a nurse. I no longer feel like you care about me or the people you say you serve. When we dare to think we are finally getting the love and support we deserve, we get a pizza party and free pens for the healthcare heroes. Now, Tristan's father works in a manufacturing facility in Ohio. He doesn't know the first thing about healthcare. But if you read Tristan's letter, which was published a number of times, including by USA Today, it outlines all of the problems. And he said, Corey, I don't know anything about healthcare, but I think Tristan left us a roadmap. And I agree. So what you need to understand, I think, and this came out recently from CDC, and I'll share this data in a minute, is that our healthcare workforce actually is currently experiencing a mental health crisis, a formal mental health crisis. When CDC and their occupational safety arm, NIOSH, in October of 2023, published their Vital Signs monthly campaign. In October, they identified that health workers, compared to any other workforce segment in the country, are experiencing a worse mental health conditions. They were experiencing harassment at twice the rate as they did in 2018. they're experiencing on the whole burnout now at almost 50%. And this is the one that actually is incredibly scary. The intent to leave is increasingly high. And I will share with you this piece of data, which is that during the pandemic, 100,000 nurses in this country left the profession. And if that doesn't scare you enough, the nursing associations are estimating that another 900,000 nurses are going to leave the profession in the next decade. Almost 100,000 a year are saying, you know what? Enough is enough. I'm done. So our foundation and the little role that we're trying to play here is first in making connections between different areas of healthcare. Shikar did not, my biography and my background should be, in some of the materials you have, but I was in healthcare for over 2 decades. That's the only reason why I feel somewhat competent to be helping on this journey to improve. But one of the things that I learned working in academic medicine for a long time is that healthcare is very siloed. So we need to work together and put our arms around the healthcare workforce. We also need to accelerate solutions. There have been organizations that have been working on this for quite some time, but what ends up happening is they end up publishing something that looks kind of like the Encyclopedia Britannica, if you remember that. I had those in my house growing up. But what workforce is really looking for right now, and healthcare leaders in particular, are what are the solutions I can use right now to mitigate this issue? Because I understand I have a problem. And then finally, one of the things that we've really excelled at, which is advancing policies. So we did this, as I said before, in partnership at the very beginning for us of this journey. And when I say the beginning, our first conversations with Dean Williams and the team at Thrive Global and the Creative Artists Agency began in the late summer of 2020. And what we talked about was the need to take a systems approach and to run a national coalition, because just these 4 organizations, while important, can't do it alone. We created an initiative called All In Wellbeing First for Healthcare. I always put the emphasis on well-being first for healthcare because we need to start to recognize that before we can achieve any of our patient safety goals, the well-being of the workforce first must come into play. And we have assembled a national coalition, and this is our steering committee, and it involves nurses and physicians and rural and urban and healthcare quality improvement organizations. And this group is growing and growing and growing in size to help advise us on our 2 goals as a coalition. And those are to scale well-being solutions and to remove any barriers to mental health access that uniquely apply to healthcare workforce and therefore negatively impact the public health. So let's speak for a minute about that second goal of ours, because as we've already talked about, this may be new to you on this call. During our work, what we've identified is that there are at least 6 known barriers for licensed health workers in obtaining mental health care. And they are often asked in surveys why they don't get mental health care. And they almost always talk about both the institutionalized stigma and the cultural stigma, I should say, the cultural stigma associated with getting mental health care, but also this institutionalized stigma around these penalties that they obtain when they are asked questions about have they ever had mental health treatment in their life. And this really opaque set of consequences about what happens if I say yes. And I can never say yes on my licensing application or my hospital credentialing application or my commercial insurance credentialing application or my malpractice application or other things. In case you're wondering how we built a chorus around this issue, we've worked with the United States Senate. You'll see this theme a lot. We helped work with some United States senators who wrote a letter to the Department of Justice who said these questions should not appear on applications anymore. And we believe these are violations of the Americans with Disabilities Act. Therefore, we want you, DOJ, to enforce these questions. Well, DOJ responded in the last 12 months to say it is clear that intrusive inquiries regarding an applicant's prior mental health history run afoul of the Americans with Disabilities Act. You can't get more direct from the DOJ than that, friends. So one of the things that we've really championed as a coalition and through our all-in partners is this toolkit, which we have given out to thousands of licensing hospital systems and hundreds of licensing boards, because they're not thousands of licensing boards. And it walks them through three phases of work: auditing their current set of questions against our standards, changing the questions in compliance with our standards, and then the most important part of this, which is the communication of what the rules are to the workforce. One of the things I mentioned about Matt Gall when I talked about him is that he thought he was going to lose his license when he moved from Minnesota to North Carolina. A state, by the way, when he moved, Minnesota had overly invasive questions and penalties associated with this, to North Carolina, which didn't. But for us as a family, I will tell you one of the things that breaks my heart every day is that my sister-in-law was convinced that in New York, she was also going to have that same consequence, which is one of the reasons why she took her life. But Lorna didn't even know the rules. She just assumed they weren't in her favor. And what's sad to say is that when you look at this map that we did as an audit of medical licensing against our standards, the dark colored states, including New York, don't have questions on their licensing exam. And so one of the things that we've done in addition to auditing is we've created this national badge, which you'll see on the right side of the screen, which is our champions badge for licensing and credentialing, because we want health workers to understand that where they see this badge is a sign that they can obtain mental health treatment without fear of negative consequences. Now, I know a lot of things in healthcare take a long time to fix. This is not one of them. In November of 2022, we published this map, and at that time, 19 states were purple, at least purple on my screen. Just a year later, we have now 27 states that have already made this change, with another 11 more that are teal colored that are almost complete through the change process. This is already benefiting 700,000 physicians in the United States. Sadly, nursing is way behind in this. In fact, we have not even been able to get a complete set of applications from any nursing licensing board until about a week ago, when we obtained 3 licensing board complete applications. Nonetheless, we co-authored an article in October, which identified on incomplete data. Don't worry, Shakar, it was appropriately asterisked. You did a great job on that legal disclaimer, by the way. That at that time, we thought about 13 states at best had questions that were compliant with our recommendations. In addition to the work that we've accelerated for states on a licensing level, we've also started to bring in hospitals on a credentialing level. And you'll see in purple a list of growing numbers of hospitals. I will tell you that since you all are in Massachusetts, we are working with the Massachusetts Hospital Association to bring all the Massachusetts hospitals into compliance with this work. To the extent that you might be interested in looking at our work in this toolkit, or you might have friends that might benefit from it, please use this QR code. Our tools are free. We operate under a grant for this part of our work, so please scale them. What I would share with you, just going back very briefly to this, because I know my audience and I agree, and I'm sorry, I missed an important journal that we were in. So you'll notice in this grouping in purple, there are a lot of hospitals in the Virginia area, which is where I'm based. Well, in 1 year's time, we were able to change the licensing law to benefit 500,000 licensed health workers in Virginia in all healthcare professions, and change the credentialing questions in 75% of the hospitals. All that to say, this work was recently published in the American Journal on Public Health in the last 2 months about that impact of the work. So I know I'm getting tight on time and we want to have a lot of time for discussion. Friends, one of the things that I would tell you that was one of the few benefits that we received from the publicity that we did not want following my sister-in-law's passing was that we received a phone call from our United States Senator Tim Kaine, who sits on the Senate Health, Education, Labor, Pensions Committee. And I'm pretty sure that when Senator Kaine contacted us to ask what he could do in his capacity on that committee, he didn't know that I had been in healthcare my whole career, and I was going to give him a very, very long list of things that I thought needed to happen. A few months after giving him that list, he called back and he said, Corey, I want to name a law after your sister-in-law. He said, this isn't going to solve everything, but it's a start. And so birthed the Dr. Lorna Breen Healthcare Provider Protection Act. And for those of you who have done policy work in the past, I'm sure many of you have, you will also be well aware that new programs, new law often takes a decade to 2 decades to come and get through the process. We were able to pass the Dr. Lorna Breen Healthcare Provider Protection Act and have it signed into law in 18 months. So what does this law do, you might ask? I'm sure that's what you were going to ask me, Shakar, so let me beat you to it. It provides over $140 million in new programs for hospital systems. It has created a campaign that CDC has been running with our foundation called the Impact Wellbeing Campaign, which is a focused effort on hospital leaders to give them those practical tools on what they need to do in their hospital system. As we go to reauthorize this law already, because I just told you it passed, but it's up for reauthorization already, we're focusing on the number one driver of burnout, the increased administrative burden, as a way to further enhance this law in that the programs that will be funded to focus on reducing the administrative burden of the workforce. Now, I would just share with you that this law is accelerating at a very quick pace through the approval process. We have already passed the first 2 of 7 hurdles, those being through the House of Representatives, Energy and Commerce Health Committee first, which is where I testified on February 14th. And then a few weeks later, the full Energy and Commerce Committee. We are anticipating that the full United States House of Representatives will vote to approve this reauthorized law, which we are trying for 5 years so that Corey can spend a little more time doing the work rather than being in Washington, D.C., telling the legislators what needs to happen. And we anticipate that the full House will vote imminently on that, and the United States Senate will then follow suit. And then it needs to be funded like all laws do. It will provide annually in its new form $45 million every year of new programmatic funding for hospital systems. To the extent that you feel interested in sending a quick email to your member of Congress, if they've already signed on to this law, it sends them an email and it says, thank you for supporting the Lorna Breen Act. And if it hasn't, it says, please consider supporting the Lorna Breen Act. It'll take you 20 seconds of time. We have already sent about 5,000 messages through this instrument to members of Congress, and they are paying attention. To give you very quickly the 2 images of the work that has been seeded by the Lorna Breen Act. There is a group that has convened 44 organizations who have received grants from the Lorna Breen Act. That group is now is being led in collaboration, a collaborative between IHI, which most of you probably know is the Institute of Healthcare Improvement, and GW. They are the conveners of 44 organizations who have received Lorna Breen Act grants. They've called their work the Workplace Change Collaborative. And then, as you heard earlier, we have launched the Impact Wellbeing campaign with CDC. We have just published this co-branded guide with them in the last 30 days. As I transition out, I'm going to leave you with 2 thoughts. One is about 90-second video overview of our work, but then the other is this quote that we use a lot in our work from Margaret Mead: "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has." When I think about our early days working with Dean Williams, working with Shakar, and working with our small group of dedicated individuals, we didn't think we were going to change the world, but what we did think we were going to be able to do was make a positive impact on the workforce, and we certainly have done that. And I really am so incredibly grateful for Shakar and Dean Williams's ongoing support of this work. So with that, I'll leave you with a 90-second video, and then we'll have plenty of time, I think, for questions.
Picture a class of 4.
Whoops. Sorry about that, everybody. Here we go.
Picture a class of 400 medical students sitting in a lecture hall learning how to be clinicians. That's how many physicians die by suicide every year.
Physicians and nurses die by suicide at twice the rate of the general population. Suicide, mental health issues, and burnout are at a critical level among our healthcare workers. These pressing issues demand our attention and action.
To break the stigma surrounding mental health and create systems and environments that support workforce well-being.
We know that our work is having an impact because we hear from healthcare workers every day. As we listen to their stories, we are moved and inspired to make a difference.
Bringing awareness to leaders and lawmakers about the issue of mental health, suicide, and burnout among healthcare workers is essential so that the workforce can sustain a sense of hope that positive change will occur.
The publicity around Lorna's story was a rallying moment for the workforce to say enough is enough. We are working to amplify their voices, and our mission is unique. Through advocacy such as the Dr. Lorna Breen Healthcare Provider Protection Act, we continue to work for federal and state legislative change that positively impacts all clinicians.
Our goal is to take care of the people who take care of us.
To take care of the people that take care of us.
To take care of the people who take care of us. And as a foundation, this is our roadmap. We hope you'll join us.
So, friends, that's how before we get some advertisement that's inappropriate on YouTube. We will go to stop my sharing, and I'll gladly open it up for questions and further discussion. Shakar, would you like to moderate?
Absolutely, Corey. But before I do that, thank you so much for taking us through the fascinating journey of trying to achieve the objectives that you kept in mind, the kind of support that you were able to get from a variety of stakeholders, and the vision that you have shown about what could be done. So I open it for discussions or questions or any experiences that people would like to share. And yes, just feel free to raise your hand and I'll give you the floor. Aisha, please.
Hi, thank you so much for the presentation. It was also incredibly moving. So I think, I mean, you talked a lot about some of the policy actions, particularly with regards to nurses and doctors seeking healthcare for mental health. But could you talk a little bit more about some of the sort of systems level changes that need to take place? I know you talked, I mean, you highlighted reducing administrative burden, but what are some of the other key priorities that you think would make a tangible difference to at least the burnout piece?
Aisha, thank you so much for that. And this is emotional for me, as you can tell, and I think it's personal. When I'm in rooms with physicians and nurses, when I ask them if they know someone who's died by suicide, almost every hand goes up. And that's just, I don't know any other industry where that's the case. And so it's just wrong, to be honest with you. I appreciate the question around burnout, because when I do this as a longer, I'll tell you about the program that we've created. And let me do that in the answer. So it's called All In, Caring for Caregivers. And in that program, we bring groups of hospitals together and we march them through a journey. It's got 3 phases, because I learned in business school, you can only really do 3 things, right? The very first phase is focused on eliminating these barriers to mental health access. The second phase is educating health leaders on the 101 of this and what they have in their sphere of influence and control. And then the third phase of the work is through an operationally focused initiative in that is focused in a couple different domains to mitigate burnout. So that's where I'll go. So what we know, the data continues to show that the primary driver of burnout is the increased administrative burden. And when you think about conversations that we have in the United States right now about workforce shortage, and then you look at the amount of time that nurses and physicians on average spend away from the patient, but working on administrative work, what you realize is that half of a nurse's time and about 70% of a doctor's time is spent away from the bedside. And so every percent increase in or decrease in administrative burden not only decreases not maybe one-on-one burnout, but it also certainly increases the clinical ability for us as well. Within the administrative burden realm, we drill into the focus on the electronic medical record and a lot of the policies and the operations within the way that the EMRs were developed. It's for me, the EMR conversation, particularly because it's only been in the last 10 to 15 years that this has really come up, is the equivalent of the boiling frog for hospital workers, right? It's just more and more is layered on. And then finally you're at a point when you're boiling and you've got to get out of the pot or you're dead. Prior authorization work is a really key driver of that burden, but the number of clicks that they have to, and the inefficiency in the patient exam and all of the before and after work, which is called pajama time. It's actually a formal metric. That's really our big focus. The other thing that I would say to you that we really focus on is taking what we thought of as triple aim goals, quality goals of low cost access and high quality patient care, and expanding the aperture to include the impact of the work on the workforce in all of the quality improvement activities. So I'm getting a little bit more tactical, but because we know that the workplace is so inefficient right now, and I don't know, are you a physician or a nurse or in the clinical environment at all? But what we hear is it's so inefficient that we understand that there need to be a number of tactics to make it a more efficient environment for them. So those are the big drivers. Other things, you saw it in my slides. Workplace violence is another big one. It's increasing. It's not the sole driver of it, but violence against health workers, threats against health workers. For me, those are all icing on the cake. But our big bullseye for this work is the administrative burden, both from a policy perspective, but also just a day-to-day operational perspective. Does that help?
Yes, no, it does. Thank you so much.
And I will just tell you, Aisha, one of the things to know, and if you look back at Medscape's annual survey of physician burnout for the last 5 years, even during the pandemic, the number one driver of burnout was increased administrative burden. So even, and your eyes have to fall all the way to the bottom of the scale to see where COVID appears, even during the peak of COVID. So we know that for us, this is a matter of chasing and focusing right there, and understanding that that's where you're going to get your most bang for your buck.
Thank you.
Yeah, you got it. Shekhar.
Thank you, Corey. We still have time, so any further discussion points, questions, or experiences are most welcome. And as people are thinking about it, I have a question, Corey. Our department does a lot of research. There are people who are doing full-time research. I do know that you have a considerable amount of data and research findings, but there must be things that you feel you need to look for, additional knowledge that you need to have to fulfill the requirements of this agenda better. If suppose somebody is willing to spend the time to do more fact finding, more research, more evidence-based interventions, what would you suggest?
Well, I'm glad we have 9 or 10 hours left for me to itemize the whole list of things for you in this call, Shekhar. Let me bucket up. Let me go back to my Venn diagram. This is me talking about my Venn diagram. So I think in each one of those domains, there's ripe opportunity. From a burnout perspective, what the systems change work is there's a lot of theory, but there's not a lot of practical and scaled implementation of concrete solutions. So I think there needs to be research into these organizations like the 44 that were sponsored by the Lorna Breen Act, into understand the effectiveness and the scalability of those solutions. There's also, so that's one. The whole conversation around burnout and the impact on patient care in and of itself is one, because there was a study that we used to quote that showed that there was a 200% increase in medical errors when the workforce was burnt out. However, I believe that some of that was pulled back. When you think about, and I used to say on that one, in the operating room, if there was a surgical instrument that increased the medical errors by 200%, it never would have made its way into an operating room. And yet we're letting workers take care of patients all the time. And so this conversation around what is the impact on the quality of patient care from the burnt out population, I think is really an important one. Culturally, leadership wise, we absolutely need more data into what are effective means of, again, changing the culture. What are the cultures that are allowing for this self-care before other care? You know, the oxygen mask principle on the airplane. And then the other piece that I really look for is there's a whole body of work that I think needs to be done around the mental health as we knock these barriers down, and as the workforce begins to understand that they are no longer penalized, how we see a change in the impact on the positive mental health of the workforce, potentially the uptake in in patient care, the utilization of mental health services, those sorts of things. So that's my short answer. But that kind of lines up with at least my thinking right now of how our Venn diagram and our work at least is focused.
Thank you so much, Corey. Invite
yeah.
Ayagoto to ask a question.
Yes, thank you very much for your impressive presentation. I keep working as a public health doctor in Japan, and this workplace change for physician is a major issue right now in Japan. And one difficulty that we face is that the understanding of the public about doctors are not robots. We are not there 24 hours every day. And I hope to learn how you deal with this in the United States.
You know, so thank you for that comment. Before you all came on, this was one of the things that Shekhar and I were talking about. So I will just make a comment here because I don't know that there was much of a question in that, but I will make a comment that for those of you who have ever been on an airplane before and been inconvenienced by limitations on the crew's ability to work past a certain number of hours, it is commonly understood, I think, among the general population that that is for your safety. Yet there is nothing commensurate in the general public about the fact that there should be duty hour restrictions and other things in healthcare that benefit them. And I think that there needs to be a large public awareness campaign similar to the campaign. You know, there's been, and I don't know if this is the case in Japan, but it's certainly in the United States, the increase in violence and threats against health workers that you saw in that data, a lot of it really amplified around COVID, vaccines, everything else in the United States, that the public needs to understand that these are humans, right? In all cases. And so there's a lot of different ways that I think we need to do that education. But until the general public really understands it and embraces it and knows what they can do about it, I think we're going to be in this divide. I will just add one thing for you. I mentioned this during my talk. So one of the reasons why it was important for our family to speak out after my sister-in-law's death is that 11 hours after she died, the New York Times published her cause of death over our objection. And when they did that, it was the worst. We couldn't have thought of anything worse than what had just happened 11 hours before, and it happened. And yet, after we kind of collected ourselves, my wife and I decided that we needed to let the general public understand what was happening with health workers. And so about 24 hours after that, we went on the Today Show We did not go within the healthcare industry on purpose because we wanted to focus on the general population, not the industry. Because the industry doesn't change on its own without external pressure, to be honest, right? Either financial pressure from policymakers or something like that, or the general population. And as someone who'd been in healthcare for a long time, I was very aware of that. So you'll see if you look at our list of publications, in fact, a lot of our publications have been around the in the general population, not academic journals or not healthcare journals, because I want the general public to know this is a problem. We have a long way to go, but I do think that part of the change in Japan and other places is making sure there are more stories about humanizing it. At Mass General, Carrie Cunningham is a female surgeon who had substance use problems. She has spoken out. I was talking to her this morning. There was a huge piece written in Guardian about Carrie. She was the chair of she was the president of the Academic Surgical Society of the United States, and she used her outgoing address to have this big sharing of her personal experience. I think another piece of this is for physicians, nurses, and other health workers to feel comfortable enough that they can be vulnerable and they can tell their personal stories. If there's anything that I've learned from all of this work, is that the power of storytelling is just where it's at, right? It is connecting with people at the heart and the head level. And I think it's going to be encouraging health workers and many, many others to speak up about this in a very public way to get the attention. So you didn't ask me a question. I just kind of gave you my thoughts on it. I hope that was okay for you, and look forward to chatting more at some point if you'd like.
Thank you. Thank you very much for the wonderful stories and examples.
Yeah, for sure.
Thank you, Corey. And you referred to the fact that 44 organizations have received grants under the Lorna Breen Act. If somebody is interested in knowing more about it or even applying for a grant, do you have some suggestions?
I do. So those 44 organizations those grants are almost done. When we reauthorize the law, note I just manifested that. The grants process will be run through HRSA again. That's who ran it the first time. What I'll do is I will put in the chat the list of the grant recipients right now on our website. There is a section on the Dr. Lorna Breen Healthcare Provider Protection Act, and in that section has a link to those grant organizations. But right now sadly there are no more grants to be given, but the work that's being done, the important work that's being done, can be tracked, and it may be that you all are working with organizations that have received them. I can't remember if anybody in the Massachusetts area, but New York is quite just down the road, if you will. And Mount Sinai is one of the organizations that received a grant, but I just can't remember off the top of my head about Massachusetts.
But Corey, if the act again gets extended, do you foresee more funds to be available for more grantees?
Yes, $45 million a year in grants should come out, and that will be administered by HRSA. So anybody here needs to be flagging workforce grants on HRSA, and many of you probably know better than I how to track different kind of grant opportunities, but those would come out. And the congressional year is at October 1 to September 30th. Our work under the law, those grants expire this September 30th. So it would be in the fall of next year when they would probably put out for that other grant cycle, unless Congress does something miraculous and agrees on something and gets the grants already pre-approved and the funding pre-approved. So
right, that's
but
very useful.
Yeah, and Shikar, I just want to point something out because I know, and it looks like somebody came off mute. So just when I testified the first time in favor of the law and the second time in favor of the law, we were the only law being considered that looked out for health workforce. There is not another one on the books like this. And in fact, I'm going over to Belgium in 2 weeks to highlight this work in front of the WHO because I'm not sure there's another one in the world. So I think that what I would hope you all understand here is we are breaking new ground, and we need to layer on top of this law and not make it the only law. There need to be others, particularly at the federal level, but certainly at the state as well. I don't
Thank
know
you,
if Robbie
Corey.
had
We
it.
still
If
have
Robbie, yeah, did Robbie
we
have a
still have
question?
a few minutes, so welcome any further questions or comments.
Corey, thank you so much for your presentation. It was really great hearing from you, and I think some of the statistics you shared as well as perspectives, it reflects poorly on society as a whole. I actually had a question to ask you, specifically in terms of just how difficult it is to become a nurse or a doctor. And I'm wondering if you have any suggestions, both in terms of policy or in terms of institutional changes that medical schools or nursing schools can take up to better support the mental health of healthcare professionals from the get-go or from the start. And I'm wondering if you had any thoughts about that.
It won't surprise you. I certainly do, Robbie. And in fact, I would say it begins before that. It really begins in pre-med, particularly for physicians, particularly around the cultural pieces. I think you need to me, when you're talking about the student population, in particular, where we need to focus in parallel are on the cultural components of healthcare that always put others before self. Always. And I think that generationally, the current generation in nursing school and medical school gets much more of it. But when they get out, even into residency, the establishment squashes it, right? So I think that the schools in themselves, and understand that in a medical school or a nursing school, you have the practitioners as well, right? You have the season that the schools need to understand that culturally, you got a different generation when their expectations are, and it's backwards, right? So you've got all of that work that needs to happen within the schools themselves. When it comes to the individual supports, this was such a big deal for the medical students who listened to a talk I gave about 2 years ago, that they've created chapters of our organization in medical schools across Virginia, Massachusetts, starting to get them, and many others. And the students are right now in the process of evaluating and comparing notes between what does my school give and what does another school give. And so I think it's an evolution in terms of what services on the individual support side are important, but things like educating them on what the rules are when they get out in terms of licensing and credentialing, that for them to understand what those rules are, understand what access they currently have, understand that using that access isn't penalized. The other thing that I would just say about the educational environment is that, particularly now, I'm going to pick on the physician environment for a second, only because in almost every medical school, you do your first 2 years in the classroom and then the second 2 years outside of the classroom. But what that does is it lends itself to understand that there are targeted times in the educational process when the stress levels, when the isolation, when things are just known to happen. And so this is the part for me, Ravi, that I sit back as someone who went to business school and law school, but never a medical training. And I look and I can look and find 15 different ways right out of the gate to make it better. And one of those is just very simply plotting out what are the things in their normal educational cycle that are going to be those spikes in mental health challenges, for example, and making sure that the intervention is there. The last comment I would make for you, Ravi, and this is more of a longer term comment, but I have yet to find a medical school or nursing school that is preparing their students for the known stressors and traumas that they will experience on the job, and how to appropriately deal with those traumas. And I will point to my sister-in-law who never had mental health care. She was 49 years old. I actually think that had she had experience with mental health before that, she'd probably be here and you and I wouldn't know each other. But what I found working with a researcher in the New York area during the pandemic was that the amount of substance use, as an example, was spiking among health workers. Well, it makes perfect sense when you understand that they might be penalized if they get formal mental health care. They're gonna use something, right, to get through. But to me, there's also a part of the training which just needs to be when you're sued for the first time, that's a non-stressor. When you see a patient die for the first time, when you see a near miss of a patient almost with a medical, there are these known triggers during the professional career that are traumatizing. And yet the training that's been told to me is the ostrich. It's put your head in the sand. It's ignore it, be tough. We don't show weakness. Just stiff upper lip and keep moving. That works for some people, but a lot of people it doesn't. So again, to me, those are the students. And I know we're close to time, but again, those are just my thoughts. Those are my thoughts and not the thoughts of Harvard. I've been told at the top of this hour, right, Shikhar?
Thank you so much, Corey.
Yeah, you got it, man.
We are out of time, but I want to thank you for coming and speaking to us, for doing all the excellent work that you do, but also sharing some of the experiences for yourself and your family, which were not happy, but you were very kind to share all of that with us. So very, very grateful. Thanks to you.
Well, we could not have done this, Shikhar. I would never have had the strength to do this without your partnership, without Michelle's partnership, without that group that really helped us. So thank you right back. And thanks to all of you for your excellent questions today. Would be more than happy to follow up in any private conversations that anyone wishes. And Shikhar can share everyone my contact information, and everything's on the Dr. Lorna Breen Heroes Foundation website, which is drlornabreen.org if you want more information. Thank you so much for having me today. It's been an honor to be with you all.
Thank you, Corey, and have a nice rest of the day.
Take care, everyone. Bye-bye.
Thank you, everybody, for joining in.